start the presentation this time.
Thank you. Welcome. Today we're going to talk about wound classification. It's important for you to not only be able to find abnormalities in the skin, but to understand how to assess those abnormalities to measure any wounds that you find consistently. Dr. Karen Zolkowski. I'm an associate professor at Montana State University. I'm also editor of the Journal of the World Council of Enterostomal Therapists and WCET International Ostomy Guidelines. The WCET actually does wound ostomy incontinence and has members from over 60 countries around the world. So an editorial board member of Ostomy Management in Advances in Skin and Wound Care journals. I'm a legal consultant and a former National Pressure Ulcer Advisory Panel member. How to assess a wound and measure it. And if you find you have any questions during this webinar, please talk to your quality and improvement specialists and follow up with them so they can answer these questions to your satisfaction. Your skin assessment and you wound. It's important to determine what kind of a wound you found. The treatment is dependent on the wound type. If we're not getting blood to an area because of arterial disease, we vascularize the area to get the wound healed. Only for pressure ulcers do we stage the wound. The ulcer is not staged. Important because each kind of a wound has a different etiology, and our treatment may be very different. Wounds are clear-cut. In fact, multiple factors that affect their ability to heal or cause their formation. You can have a vascular wound, bacterial, igneous, or can have components of each. Neuropathic or diabetic wounds that result from a lack of feeling, especially in the feet. You can have your associated dermatitis. And a focus today will be pressure ulcers. Keep in mind there's other wounds that may be very unusual, such as snake bites, spider bites, some reactions, and some things like Nicolau syndrome result after an immunization. Very unusual wounds. Etiology wounds are uncommon. With this foot, there's very large distinct wounds on it. We have diabetes and caused neuropathy in the foot. They couldn't feel their shoe rubbing. Resulted in the wound next to the big toe. Could all have been the result of the wound on top of the foot, or that wound could actually be arterial in nature. Wound be from pressure, combination of pressure and lack of blood. So wounds all have commonalities. They all have differences also. We would get the diabetes under control, which to get blood to the area would have to relieve the pressure. So it would not be as clear as you would like it to be on what was the exact cause of the wound. Mutated skin damage occurs fairly frequently, especially in our older population. Incontinence is a major issue, especially among older females, and in the past hasn't been well talked about. In today's world, we're actually seeing more advertisements for it, more discussion of the fact that it can be a problem for women, especially. This is also called perineal dermatitis. Sometimes it's called diaper rash, associated dermatitis. It's difficult sometimes to distinguish this from a pressure ulcer. In times you have both together. Important to note, the damage can come not only from urine and stool incontinence, but it can result of perspiration or drainage from a wound that's pooling in the lowest point. Acute skin damage is an infection of the skin. Frequently, when it's from urine or fecal incontinence, we see perineal area on and between the buttocks, into the folds, and sometimes down the inner thighs. There can begin with papule and vesicle formation, and sometimes actually open and you see tremor or weeping of the skin, which actually makes the skin damage even worse. It's usually shallow or superficial, and this can be irregular or can be very diffuse. Around the wound from exudate, you frequently see whitening of the skin. And from having your own fingers show maceration under a Band-Aid when you got it wet, that skin can peel off very easily. So I these people across the bed, the skin can actually peel away much of the skin on their bottom. If we have damage to the epidermis, it means bacteria can enter in skin. We no longer have the protection. Therefore, we can have an infection or cellulitis result. Look at the picture on the side. Diffuse area of redness, and you'll whiteness on it. We had a barrier cream put on, and cream should be reapplied every time the person is cleaned or died. Important to inform the family and the patient of why we're putting this cream on. Important to know which cream is being used, because levels of cream and multiple tubes can be found in the room. Therefore, it's important for staff to take ones that are no longer being used out. The correct cream is always applied. Two, if you have a stage 2 or 1 pressure ulcer, you have cream on, it's almost impossible to keep a dressing on. At that point is a decision point. Important for the staff to decide, are we using a dressing or using cream? Which are we doing first? I want to follow it. The worst thing that can happen is that a new shift comes on and decides to completely change the plan. One person's going to have to make the decision and communicate that decision well. It's often very difficult to distinguish between this moisture-associated damage and a pressure ulcer. Damage, a pressure ulcer often has distinct edges. See something in an area of pressure, very distinctly in that area, then it's your ulcer, not moisture-associated damage. Damage can be from other sources. And something that's fairly new, there's a big emphasis on this now. The straps from boots, heel boots, straps, tubing, or stockings lead to pressure-induced ischemia of the skin. And these are unusual spots. It can be upper thigh from a leg bag strap. It can be the result of tubing that the patient's been laying on. Catheter tubing, it may be on the upper thigh. Oxygen tubing on the shoulder. And for oxygen tubing on the face, keeping the skin is thinnest on the face and break quickly. So it's to make sure that this is not too tight, it's not damage to the neck or chin area, and padding if necessary. These wounds or pressure ulcers are counted separately for our incidence and prevalence. They're divided pressure ulcers. Ulcer is defined as a localized injury to the skin and or underlying tissue, usually a bony prominence, and it is a direct result of pressure or pressure in combination with shear. Friction has been taken out of this definition. Most often causes damage with our moisture damaged skin. For pressure ulcer, you must have pressure. Muscular force. It can be tissue and therefore restricts the blood flow. This in turn causes ischemia and necrosis. It enters the cells and vessels. It causes tissue deformation. We think about the fact that many of our older people already have poor circulation in their vessels. Understand that there are small vessels, all bad circulation. So already having less blood, less oxygen, less nutrition getting to their tissue, and you put this pressure on, this perpendicular force, it doesn't take nearly as much to shut off the blood supply in that area. So they're less able to tolerate any amount of pressure. Force parallel to the skin. Sitting down in a chair, and you can feel your tissue going one way and your bone going another. It stretches and distorts the internal tissue, and it's occlusion of the vessels perpendicular to the skin surface. This leads to ischemia and necrosis, and then continued shear forces on your skin and vessels. Big wounds that start really deep, right around the bone, especially the sacrum. There are stages or categories of pressure ulcers. Stage 2, 3, 4, unstable, and affected deep to injury. And talk about each of these in detail. This itself is based on the type of tissue that you can see or feel. Your stage of pressure ulcer, it doesn't become a 4 to a 3 to a 2 to a 1. A stage 4 pressure ulcer on your patient. You're healing stage 4 or you have a healed stage 4. Keep in mind, only heal to about 70% of its former tensile strength. So noting that scarring on your skin assessment is critical to understanding that this area can break down very quickly, and that places the person at very high risk. Stage 1 or stage 2 pressure ulcer. These are shoulder thickness wounds. Stage 1 is non-blanchable. Stage 2 looks pretty like a blister that has ruptured. And 4 are a full thickness ulcer. Unstable simply means the wound is covered with such necrotic tissue, we can see how deep it is. And to move the necrotic tissue, we can't tell that it's going to be a stage 3 or 4 because it has necrotic tissue. Deep tissue injury is purple. It looks like a bruise. It's very difficult to tell if this may be a bruise. You find these on people coming into the emergency room. Much better to begin care planning because you suspect it may be a deep tissue injury than to get out 2 days later that it opened up and you had a full thickness stage 4 pressure ulcer. The epidermis is intact. But blanch when you push on it. Think about you've been sitting in the summer with shorts on, with one leg crossed to the other. With your top leg, your bottom leg is red. And if you push on it, it turns white. That's it. But if one of your patients over and the bottom is very red and push on it and it doesn't turn white, then stage 1 pressure ulcer. It's difficult to identify in darkly pigmented skin. And it's critical during skin assessment for you to and feel the skin for any areas that feel different, warm, cold, soft, hard. Something that is very painful. Listen to the patient and inspect the skin carefully. SQ is also a partial thickness of the epidermis, down dermis. It's a vallow open ulcer, odd pink wound bed, and you never have eschar or slough in that wound. It makes like an intact blister. You do not open the air if there's fluid in there. You cover it and protect it and let that fluid reabsorb or let it open naturally. Tiny or a shallow ulcer without sloughing or bruising. Used to describe skin tears, tape burns, incontinence-associated dermatitis, maceration, or excoriation. So you need to know there was pressure to her ulcer. S3 is full thickness. It's through the dermis, made down into the subcutaneous fat. You will see bone, tendon, or muscle. Some slough, and you may have some eschar present. The depth of pressure ulcer varies by anatomical location. The tissue that's on your face is very thin. So it takes much to get through that tissue to actually have a full thickness pressure ulcer. Deep in other areas of your body where you have a significant amount of adipose tissue. Behind, you do not see bone, tendon, nor can palpate it. A stateful thickness. You have eschar or present and see or palpate bone or tendon. This is even including muscle. The depth is by anatomical location. That extends so far down and the bone is actually visible or you can palpate it. You consider osteomyelitis with these patients or an infection. And it would have to be treated before you actually begin to heal the wound. Unstable is full thickness. When it opens or you remove the dead tissue, it's going to be a stage 3 or 4 pressure ulcer. But the wound is because there's slough, which can be yellow, tan, gray, green, brown, or eschar, which is usually tan, brown, or black, and usually a little bit harder. When removed, we can't determine the depth. We'll find necrotic tissue on the heels, especially black, stable, dry eschar. We want to leave it there. Think circulation of the person's foot. You know people have circulation resulting from their other comorbidities. And remove this and heal. We're going up for a serious infection and possible amputation of the foot. So focus on and keep it dry. Keep the heel elevated. We see it becoming heavily infected or painful, we're going to leave the heel alone. If the deep tissue injury is purple or maroon, can be unusual spots. Think of one that was riding an ATV and fell and laid on their cell phone in their pocket for several hours before someone helped them. A person who couldn't get up off the toilet for a day because they lived alone. And that one actually had a perfect outline of the toilet seat that looked like this. And 2 days, it started to open and was full thickness. It is preceded by tissue that can be painful, firm, mushy, or boggy. Can also feel warmer or colder. A tissue injury may be very difficult to see in darkly pigmented skin. It's often the color of a bruise. Thin blister over a very dark wound bed, and you see often in the heel. They're evolved and be covered by a thin eschar. And you blister, and underneath it can look black or tan tissue. The evolution can be very rapid, and like I said, become very deep, exposing many additional layers of tissue with or without treatment initially. It's say with certainty what you're seeing. In the picture, it is a bruise, and it results from a fall this way, and it opened up. Document it and start care planning for it because it's suspected as being possible deep tissue injury, and it opens up into a large wound. Then you're not providing adequate care planning, and you're going to have problems later. So it's document exactly what you see, then to facility-acquired wound. Suspected deep tissue injury can be falls, be a fall at home where the person's been lying there for a while, can be long OR, ER times or transportation times. Think of rural areas, for example, where I live. I report it to my local hospital, which could take 20 minutes on county roads. From there, they would ascertain that I broke my hip, transport me an hour away to a major center in Billings. This has probably been on a backboard. This is the reason I fall. I'm to a second emergency room, to surgery, and this could have been immobilized for quite some time. And also results from splints or accidents. It's important to look at where they are and understand what could have caused them because they can be in unusual places. Also, medical device-related pressure ulcers account for a little over 9% of all the identified pressure ulcers. And facility-acquired pressure ulcers. The most frequent location is you put oxygen tubing around it. Sacral coccyx region from some of the patients been laying on. Base of the buttocks. And the bariatric patient. Check between the skin folds and thighs. This is difficult to visualize when you're doing your skin assessment. And at times important to bring a flashlight with you so you can really adequately see into the skin folds. You want to bring a flashlight if you don't have adequate lighting in the room to look at your wound and to actually document the wound characteristics. In the skin folds or thighs of our bariatric patients, you may find a rash. It might result from maceration. You might have a bacterial or fungal infection because they can be very moist areas from perspiration, and these areas may also break down. Ulcers in unusual locations. Be a very large person that's been sitting in a small chair. Think of someone on the airplane trying to sit in economy class. So you may wounds in some odd spots. You need to question the person and understand that they could be the result of pressure. The wound, and how we want to take the time to access the wound. Get the tissue in the wound. What is it? What color is it? At around the wound. Inflammation? Is it water from the wound? Is there green tissue in the wound showing healing? Is there a combination of different tissues as the wound is progressing? For infection, no signs of infection now. We have no odor, no green charge. That doesn't happen later because keep in mind this is a break in the skin. And especially in any of our patients that are immunocompromised, they're very susceptible to developing an infection in that wound. Anyone that's had a dirty traumatic wound, very susceptible to developing an infection, and it occur quite suddenly. Look at the moisture amount in the wound. Is there a moisture in which we're going to pick a product or treatment to excessive moisture, and we need to be very careful that we take care of the surrounding skin so the moisture doesn't macerate it. A dry wound, we're going to need to add moisture. So our goal with assessing the moisture is not only the type of exudate, the color, the amount, but also then to use as part of our treatment plan in selecting a product or treatment. Look at the wound edges. Are they rolled under? Is there unlining? Or are they progressing toward the center in a normal healing pattern? And remember, all these TE can change every characteristics. Wound change as the wound either gets better or fails to heal. And it can very quickly. So you need to know that this is an ongoing assessment, not one time, once a week deal. So you also unit the length, the width, and describe the location and the stage. You need to or drainage amount, color, and consistency. You decide is there tilling or undermining and exactly where it is. The first type of tissue. In other words, is there 90% granulation tissue and still 10% slough in the wound? The wedges, are they attached? Is 10% attached? Is 20% rolled under? Or is there a callus forming around the wound? These are important documentation things that need to be considered, and you need to know where to find it in the medical record, either in the paper format or in the electronic medical record, to adequately document these things. You know your assessment terms, and often this is confusing for people. SCAR or SCAR, depending on which part of the country you're from, is classified or dried out dead tissue. It's usually black. It can be lightly gray in color, and it's usually fairly hard. On the other hand, liquid or wet dead tissue. It can be white, it can come in different shades, but it's obviously dead tissue. Lining under the edges of the wound. In areas of tissue destruction, you can feel with the Q-tip or see. It's important to understand that in this case, your edges of the wound are not healing normally, and that might need to be debrided or cut away. So have a healthy wound tissue edge to allow healing to occur. Tongue is a tract that extends out from the wound. And you have to heal from the bottom up. If it becomes closed over, you're going to form an abscess or pocket of fluid, and it's not going to allow healing of the wound. So important for everyone to be consistent in how they measure a wound. And understanding that you use a Q-tip to look at your undermining and tunneling. Tip in, putting it on it or marking it with a pencil, and then put it on your ruler to be able to say in centimeters how deep it extends. In undermining, think of it as a clock face. 12 is the patient, 6 is the feet. With clock face is the undermining. Is 9? Is it from 1 to 5? And then you would document it. This would be with the tunneling. And the tunneling is in the middle of the wound, and you're going to say how deep it extends into the wound and of it. Tunneling is around the edge of the wound. You're going to say that the tunneling is at the 2 o'clock location, and it is 5 centimeters in depth. Now, with wound care for years was that people measured the wounds differently. Some would be longest, length and width. It could be in a shape. What happens is that would become very confusing. So the standard way to measure a wound is now from head to toe and perpendicular to that. Head to toe axis, but you're going on the wall part of the wound. In other words, it can be anywhere on that head to toe axis. Circular to that at the 3, 9 o'clock position, again, in the washed part of the wound. It's important to note that these have to be head to toe 9, and that everyone is consistent in their measurement. I'm looking at documentation that has the wound changing size, location from day to day. And if there's ever any legal issues or other medical issues, you're not going to be able to communicate the information effectively. So you use a sterile Q-tip, and you can moisten it in normal saline or sterile water. You place it into the deepest aspect of the wound, and you finger or mark it, and then again measure the depth of the wound. It'd be done in the deepest location of the wound. This is an important indicator of whether healing is occurring, as your depth becomes more shallow. And sometimes one part of the wound will become shallow more quickly than another. So it's important to look at the wound in its entirety and the depth in each location as healing is occurring. Healed tissue is skin that's growing in a superficial ulcer. It can be pink and shiny in persons with darkly pigmented skin. It's also very fragile skin. And this definition actually comes from the nursing home minimum data set from here. A very good standardized definition that everyone should be using. And hollow or white tissue. There's to the wound bed in strings or thick clumps, and almost a mucus-like consistency. And oftentimes we can remove some of it using our Q-tip. Sometimes breathe out. We can use different ways to debride it out. It's also important to note you can't decide that it's slough or char or anything else on the wound until you've cleaned it. And so the dressing types Maybe an odor when you take the cover dressing off, or some may actually cause the wound to look yellow because of the fact that it's the what's in the dressing itself. So until you've cleaned it out, you can't really decide exactly what kind of tissue this is. And that's a heel, and it's white. It wasn't very runny. Nicks are black. In a whole wound or only part of the wound. It can also be down or tan, and it adheres very firmly to the wound bed. It's softer or harder than the surrounding tissue. If you look at both of these wounds, you'll see one's really black and hard on your right, and the other is more shiny on your left. Those are areas that have to be removed for you to tell the depth of that wound. But when you find this necrotic tissue, you're going to then decide at this point, is it palliative or curative? If you're palliative care, I need treating the wound the same with modern dressings or treatments. The goal is now to provide comfort in whatever is bothering the patient, be it the moisture amount of exudate, be it odor, be it pain. So I'm not looking at healing that wound completely. If it's, I'm asked to breathe this out in a variety of ways, depending on the person's medical condition. But my goal is going to be complete healing of this wound. And there's one wound that people frequently don't know about, and this is often the wound that's very upsetting to the family. It's called the Kennedy terminal ulcer. It's based in failure at life's end. When you tell them they have heart failure, but we've never really told people that you also have skin failure. Remember, skin is your largest organ. Body systems are shut down, does too. It's very important to have the conversation with the family if one of these wounds suddenly develop. And it can be a person that got up here in the morning, their skin was fine, or CNA comes out to you in the afternoon and says, gosh, Mrs. Smith has a huge wound on her coccyx. Well, she has this wound because her skin is dying, and all it occurs right before death. So it's important to then inform the family that you found this wound and that you're really concerned that her condition is deteriorating. On people's backs, just from laying on the mattress, and this was someone who was doing really well. He was in his 90s, but had been expected to make a full recovery, and in a matter of a day or two, he had large necrotic areas on his back just from being in the bed. Wound. We've decided our plan, palliative or curative. We're going to the overall condition of the patient to dressings or treatment. We're located of the wound. Is all. What caused it? Do we need more tests to determine whether it could be vascular? What is surrounding the wound? Is it red because we have inflammation still going on? Is it she and soft, showing extensive tissue damage underneath? Drainage is there. Wounding pain. And leaves the hospital. Are they going home? Are they going to a nursing home? Is the health going to be available? It's going to be covered by their insurance. So, and how can we have consistency in treatment? It's important that both your skin assessment, looking at the skin its total, assessment, Then determine your effective and comprehensive care planning. Care planning then is going to have to be care for the wounds and understanding that regardless of what the risk assessment score is, a patient who has ever had a pressure ulcer, currently has a pressure ulcer, is a risk for developing more. It's about how to assess a wound and measure a wound. Thanks for listening to this presentation. If any questions, please share them to your QI specialist. So some resources available for you here that you can use if you wish to learn more information. Thanks for attending.